Hello everyone, welcome to another session of the webinar series on palliative care and COVID-19 pandemic. I'm a palliative care physician working in General Hospital Ernakulam, India as a specialist medical officer, and I'm also a locum consultant in palliative medicine with Holt Doctors UK. And today I'll be talking to you about managing the symptom complex of breathlessness and agitation in the context of COVID-19. So, and to learn more about how do you manage both the symptoms in the palliative care context, and familiarize with the use of algorithms of both the symptoms, which is available in the ebook, which I'll be talking to you about initially, other effective management techniques. So it'll be useful for this learning, before you start the learning, to download this ebook from this link, which gives a detailed description of all the palliative care aspects of COVID-19 and the symptom management. And in addition to that, we've also got a palliative care app, which can be used as a supplement to support the symptom control in palliative care for general settings. So once you have both of these as an additional reading matter or learning material, it will be useful to do this webinar along with it. So how do COVID-19 patients present? And this has been going on for some time now, and I think as we all know, the pandemic has spread throughout the world, and has affected almost all the countries in the world. But there are a lot of difference in presentations. Well, we can see that most of the patients actually present as a least serious variety, whereas referred to as subclinical, where the virus is present but they don't have any symptoms. Then we've got the other group which presents with the upper respiratory tract infection symptoms like fever, cough. You can also have milder symptoms like headache and conjunctivitis. And the important thing to remember is these group of patients are able to transmit the virus. Then we have got a third group of patients which presents with the flu-like symptoms, and which usually keeps the patients off work, and sometimes they can present to hospital themselves. Again, it depends on which country they are. Different countries have got different policies for managing such patients, and some countries do admit them earlier on, and some countries try and manage symptoms at home. Now, and the last one, and the one that we all, the dreaded one, is a severe illness that can present with the features of pneumonia. And the important thing to remember is, as far as symptoms are concerned, these severe illness with the features of pneumonia has a symptom complex of breathlessness and agitation. Now, the clinical profile of this COVID-19 lung disease, and when they reach towards end of life, and that is where the sometimes the palliative care gets more involved, what has been described is that there is the disease is driven with a high breathlessness or a hunger. There'll be high distress. There'll be high symptoms of delirium and agitation. There'll be high fever. And the danger to remember is things can deteriorate pretty much quickly. So there'll be risk of cessation of life over a short number of hours. Now, coming to the pathophysiology, and this can be described in a graphical form, where we can describe three stages. There's a stage one, as I described, as early infection, when the viral load is quite high, this viral infection is quite high, but the severity of illness is quite mild, and the patient can present with mild constitutional symptoms. And sometimes, few patients will just have that, but few can progress onto the second stage or the pulmonary stage, where it's divided 2A and 2B, where the patients can predominantly present with shortness of breath, hypoxia, and you can have clinical signs with abnormal chest findings, abnormal blood investigations in the form of transaminitis and lower normal procalcitonin. And further on, when they go into the hyperinflation stage, they have got the the high inflammatory response from the host, and patients can present with ARDS, SIRS, shock, and cardiac failure. And they'll have further changes in the blood investigations, including elevated inflammatory markers, increased CRP, troponin. Also, these two phases, there have got different potential therapies have been suggested. Now, again, I'm not going to details of that here because that's not in the scope of this webinar, but and lots of them are still in the experimental stage. So what is different in palliative care for COVID-19 patient? Why is it different? So as you can see, as I mentioned, it's like an ultra emergency situation. So once they reach into that end of life palliative phase, things can deteriorate pretty much quickly. You don't have much time left to look after them or provide the proper symptom control. The important thing to remember is right from the beginning of the disease and maybe towards end of life, the unfortunate situation is that there is no relationship between the patient and the family because the patient has to be isolated. So there tends to be an increased relationship between the patient and the healthcare professional because they are the only ones present for the patient throughout their symptom journey until they become better or till they reach end of life. And there is, as I mentioned, there's no typical palliation timing for sharing and planning the treatment path because things can change pretty much quickly. So all the discussions about goals of care, all the discussions about going for ventilation or not, all this has to happen earlier on in the disease. And so we have to think about that earlier on in the disease. And then deaths, as we all know, as we expect, is usually linked to traumatic psychosocial experiences for the family and the members of the treating team. And there have been lots of narratives and articles about how the physicians, are the general physicians or the intensivist or the respiratory physicians are doing more of a palliative care work now because they are the ones who are dealing with the whole process now, and they are sort of the link between the patients and the family, and the death appears to be a traumatic experience not just for the family but for the treating team also. So coming to my topic, the first half of my topic, breathlessness. So before I go on, I would like to pause and sort of would like you to actually think of the last patient who presented with breathlessness that you saw, not related to COVID, maybe not related to COVID, but how did that present, and that last patient that you saw in clinical practice. And the important thing to remember is breathlessness, how breathlessness feels to a person. It's not like any other symptom profile where you can see that you can describe breathlessness as it's not just a vital sign, but that the vital sign that is intensely connected to oneself. And we sometimes describe our life, the starting and ending of a life is often in describing terms of the first and last breath. So, and I've often seen patients describing, as breathlessness as patients have sometimes seem to say that I have been breathing all my life, but now I have started experiencing it. So that's how the breathlessness is different. Breathing is a part of our life, right from the beginning till the end. But when it becomes abnormal, when it becomes normal and pathological, we tend to start experiencing it more. And that's how complex that symptom is. And in COVID also, it's all the more complex because there are lots of reasons why it's all the more complex in COVID. Because as I explained to you, the pathophysiology of COVID is also very, very complex and changing day by day. What happens to the lungs? Initially, what we thought was mostly it's pneumonia consolidation, alveolar damage, pleural effusion, and then further on we're hearing new theories like microthrombi formation. So even to the physicians or the clinicians, the pathophysiology of COVID lung, it's not very, very clear. And then on top of that, what are the other factors that makes it more complex? The vulnerability. So as we all know, all the studies invariably in all the countries are showing that as age advances, you tend to have more, you tend to have more problems with COVID, and you tend to have the risk factors as more with COVID, and you tend to have into the high-risk category more as age advances. And also the comorbidities like diabetes, hypertension, chronic kidney disease, COPD, and also cancer and other immunosuppressive conditions will increase the risk of having a very bad COVID infection and risk of dying because of COVID. So that group of patients are very, very vulnerable, and they tend to worry more. And on top of that, patients become more anxious because there's a lot of information. Unlike any other pandemic that we have faced in the past, we know that social media and internet is more advanced now. So we tend to, right from the beginning of this COVID pandemic before it started, we had lots of information. There was information overloading from all the sources, and we tend to try and read everything, and that is going to increase the anxiety of the patients. Also, as I mentioned in my previous slide, there are some experimental strategies tried. There's still no definite treatment that is proven for COVID-19. That again adds to the anxiety. And the important thing is all these patients, when they, right from the day of diagnosis, they are in isolation till they become, and again depends on different countries. Till in some countries they make sure that two of the blood tests are negative till they actually come out of isolations if they get better. So even if even if they get better, they have to spend all the time in isolation, and that adds to the anxiety. And again, the fourth factor is the other psychosocial aspects. So there'll be the guilt if you get the disease, and if somebody else, if you tend to spread the disease to your family, the guilt associated with that will be there. The anger of getting the disease, the fear of what is going to come, because there are different ways the COVID patients can change. That is going to happen to you. That fear is there, and obviously the loss of income, which can happen to anyone. Even if you don't have the disease, you would be in lockdown, there'll be loss of income. And on top of that, when you get the illness, that will add on to the psychosocial issues. So, and all these actually can, can manifest as breathlessness. So as we all know, breathlessness is very much linked to the psychosocial aspects. So we need to look at breathlessness in all these angles, and not just the cardiac and pulmonary point of view, but it's a complex symptom which is intensely connected to both the psych and soma of the patient. So how do you manage breathlessness? As I mentioned earlier, always follow the COVID-19 management protocol for the active disease, and that should be going hand in hand with the breathlessness management. Try and correct the correctable factors, and this we say all the time to any sort of symptom management. If there's other correctable factors, try and correct them. So if there's infection, give antibiotics to treat that. For cough, we can manage with symptom management, and optimize the treatment for other comorbidities. The patient will be having COPD, so they could be more breathless because of that. Heart failure, so always optimize the treatment for the other comorbidities, and then continue with the symptom management. Treat the bronchospasm if present, and in spite of all that, and one of the terms that we have used in our ebook is something called refractory breathlessness, which we have defined as the breathlessness that is not improving despite the optimal medical management. So once you reach that stage, then that's a stage when we start with the symptom management of refractory breathlessness, and this is mentioned in our ebook. So how do you do that? Now, in any symptom, we can have both pharmacological and non-pharmacological management. Now, I'm going with the ebook. So in our ebook, our algorithm describes the patients. There are two algorithms. One is for the patient in the ward and patient ICU, and both of them, the non-pharmacological management is pretty much the same. So always try and address or try and manage the symptoms using non-pharmacological techniques like appropriate positioning, which gives a maximum comfort to the patient. So some suggestions of good positioning are sitting upright, legs uncrossed, let the shoulders droop, keep the head up, and lean forward. These are some of the positions that are known to relieve the breathlessness. So you could try that, and this could be tried either in the ward or ICU if the patient is not on ventilator. We all know about managing prone ventilation. So patients on the ventilators are sometimes managed in the prone position for better management. Actually, now the studies have said that, or the evidence to say that even the patient is not on a ventilator, you could just nurse a patient in a prone position, will improve the airway clearance and help in the aeration better. So prone position is one thing that you could try, and the other positions that I've mentioned to help with the breathlessness. And then the other relaxation techniques. Now, again, the thing to remember is once patient reaches the very acutely unwell stage, probably that is not the time to teach all these things. So we should be able to, this can be taught by the respiratory physiotherapists if they are available, or a nurse practitioner, and who are trained to do so. And these can be taught to the patients maybe before they've reached the acute or critically unwell stage, and then help them to try and do this while they have these symptoms. And again, as we all know, go with the patient in front of you. So all this may not be applicable in the acute crisis, but if it's properly taught before, then you can train them, and you can train them in relaxation techniques and breathing techniques. There are lots of breathing techniques that are available, and the simple one that I would like to mention is the pursed lip breathing, where it can be described that is like how you smell a flower and blow a candle. where you need to know that the expiration should take twice the time of inspiration. And I think we must have all seen a pursed lip breathing in our typical COPD patient. So you train the patients to actually do a pursed lip breathing while gentle inspiration and in a prolonged expiration, like smelling a flower or blowing out a candle, where the expiration should take twice the time of inspiration. And other techniques like it's always advisable to reduce the room temperature or cool the face by using a cold flannel or a cloth. One of the important non-pharmacological management of breathlessness in palliative care was use of handheld fans or electronic fans. But in the COVID-19 scenario, we don't advise the use of handheld fans to the patient because there's an increased risk of spread of infection. So that's the reason we don't advise the use of a handheld fan. But you can try various cooling techniques like cooling the room or face with a cold fan or cloth can be used. And in some patients, oxygen or high flow oxygen may be beneficial, can relieve breathlessness. And in Indian care, as well as when invasive ventilation is not indicated. But general advice is oxygen is given to keep the saturations above 90%. Then moving on to the pharmacological management. And here again, we have to divide that into patients in the ward and patients in the ICU. So pharmacological management, and we all know the mainstay of pharmacological management is low dose morphine. In the ward, what the doses that we're given is of oral morphine. You can start with 2.5 to 5 milligram per orally every 4 hours, or if a subcut route is available, a subcut or IV route is available, we can give 1 to 2 milligram subcut or IV every 4 hours. In addition, patients, as I explained before, breathlessness can be linked to anxiety and agitation. And if the anxiety is not taken care of, they can develop into panic attacks. So if the patient has got anxiety, then you can also give a benzodiazepine, where the suggested benzodiazepines are midazolam 2.5 milligram Q4 hourly, which can be given a slow IV or subcut, or we can also give lorazepam 0.5 to 1 milligram sublingually, SOS, as and when needed. Now, if the patient, now I'll be describing more about agitation in the further slides, but just to mention that if there is breathlessness with anxiety and no disorientation, then this is what we do. If the patient has got disorientation, we'll have to add on haloperidol also, which will be described in the later slides. The thing to remember about morphine is if the renal function is stable, this is a starting dose that we normally advise. Now, suppose renal function is abnormal and you don't have any other opioids available, you can still use morphine, but at a lower dose and probably with the increased intervals. So you can start at maybe 6th hourly interval or 8th hourly interval, depending on the patient response. Also for elderly patients also, I usually tend to start at a lower dose. Now, I've mentioned a continuous infusion of morphine and midazolam. If there is any provision available in your setting to start a continuous infusion, it's always better to start a continuous infusion of morphine, which can be given as IV and subcut, and you can combine morphine and midazolam together, 10 milligram of morphine and 10 milligram of midazolam over 24 hours. Now, how do you, why do we use morphine? I just want to mention a few words about morphine and why we use it in this in palliative care for symptom management. Now, as we all know, and morphine used to be a highly feared drug in this context, but now we have sufficient evidence to say that morphine can be used to manage breathlessness. And how do we know that? Because one is morphine reduces the hyperventilated response to hypercapnia, so that respiratory rates comes down, and as a result, the work of breathing also comes down. It also produces pulmonary vasodilation, which leads to which results in a better ventilation perfusion match. And also, in addition, as we all know, morphine is a good analgesic, so it will produce an effective analgesia, whereby the patient's pain associated with breathlessness is less, and the patient will be able to breathe comfortably. So there are lots of reasons why we can use morphine, and some people say that you can use it for anxiolytic also, but that is still debatable. So we prefer to use midazolam or any benzodiazepine for anxiolytic purpose. Now, moving on to management, the ICU. So it's not much different, but the only thing to note is because it's an ICU setting, parenteral administration drugs is more suitable than oral ones, because the patient might not be in a position to take oral medications. Either they can be intubated or ventilated, or they'll be too weak to take any oral medication. So what we have suggested in an algorithm is to go with the parenteral opioids, and we have given dosage of morphine 1.2 to 2.5 milligram IV or subcut 2 hourly. We've also given option fentanyl in ICU, and again, because it depends on the settings where you're working, some ICUs prefer to use fentanyl, so we've given the dosage. Also, fentanyl can be used in the ward also if the patient has got renal failure. So fentanyl is a better choice for patients with CKD. As we all know, toxic metabolites of morphine can accumulate in chronic kidney disease. So dosage we have suggested for fentanyl is 25 microgram IV or subcut Q2 hourly, 2 hourly. And then the midazolam and lorazepam doses are the same. Midazolam you can get 2 to 5 milligram Q4 hourly, or lorazepam 0.5 to 1 milligram sublingual SOS. Now, when we compare midazolam and lorazepam, you must have all know that midazolam is shorter acting than lorazepam. So if you are able to give sublingual medications, then lorazepam is much preferred. And again, we need to be extra careful while giving sublingual medications, and always make sure you have got adequate personal protective equipment when we do sublingual medications, but it is much more longer acting, so you'll have better symptom control with lorazepam than midazolam, unless you're giving a continuous infusion. And as I mentioned before, if a provision to give a continuous infusion of morphine or midazolam is available, then you can start morphine infusion 15 milligram of fentanyl 100 microgram and midazolam 10 to 30 milligram IV or subcut over 24 hours can be given. And this can be given either as a syringe pump or as an infusion pump. Now, again, in our algorithm, we have gone to another category of patients where it's a severe breathlessness. So here we have gone with a respiratory rate more than 30 per minute. So this is when the patient reaches a stage of high breathlessness stage, when they're end of life, they're clearly dying, they're very, very breathless, and the rate is more than 30. We've denoted them as significant breathlessness. So the dosage is different here. We start with morphine, 2.5 milligram IV or 5 milligram subcut. So higher dose can be given, or fentanyl, 25 microgram IV or 50 milligram subcut. Along with that, we give midazolam 2.5 milligram slow IV or 5 mg subcut, and this can be repeated every 15 to 30 minutes till the patient has got improvement of symptoms. Again, you will have to spend more time with the patient if you're giving a bolus every 30 minutes, which is again a high risk as far as infection is concerned with healthcare worker. So it's always better to start an infusion of morphine and midazolam. So the idea would be to give a start dose of 2.5 to 5 milligram of subcut midazolam and morphine, and then start a continuous infusion of morphine 30 milligram and midazolam 15 to 60 milligram IV or subcut over 24 hours. Now, this is a maximum dose that we have given, but that doesn't mean that it has to be the maximum dose. The doses can be titrated if the patient is not settled with these doses, and always call for the specialist palliative care input if that's available, or critical care team if you're struggling to manage the symptoms. But this dosage is given only as guidance, and it can be changed according to the patient's needs. Now, this is the algorithm that is given in the ebook, and this is what I've explained in the previous slides. It's given page 14 of the current version of the ebook, where we have divided the refractory breathlessness into patient ICU and patient in the ward. And as I've explained before, it gives details about the positioning, what the relaxation techniques, the non-pharmacological and the pharmacological, and then how do you manage in the ward and the ICU. And this is clearly given in page 14. That's the algorithm that you can actually print out just the page and use in your ward or in situation where you're managing patients. So just to summarize the breathlessness bit, morphine is a useful drug in relieving cough breathlessness, and it always also provide added symptom relief and quality of life. And judicially administered morphine will not produce respiratory depression. Morphine can be administered by multiple routes like perorally, IV, subcut, and PR route. And if this patient's symptoms are not getting settled, always consult with a palliative care specialist to complement it and to ensure symptom relief. We'll just move on to delirium and agitation. So again, you picture a patient who can start with breathlessness and then can become very, very agitated and restless. So think of a typical patient journey where patient can be either at home and get high symptoms of either fever or suspected COVID, and they get admitted to to the ward and is examined by the healthcare team in a busy admissions area. So imagine what goes through the mind of the patient at this stage. Obviously, there'll be mild anxiety. They don't know whether they've got COVID or not, and they're waiting to be examined. And at the same time, they'll be away from the family at this stage because they'll be isolated. So the contributing factors to the anxiety would be they'll be away from the family, they'll be worried about what's in store for them, and there'll be dyspnea also, because at this point, there'll be usually dyspnea, which is the most common symptom. What happens? The worsening dyspnea, patient goes on to become more hypoxic, and they become restless and anxious, but they could still be oriented. And on the next stage, they can go into disorientation, and further they can become agitated and disoriented. So this could be a typical pathway of a patient, and there are 2 spots or 2 points in this pathway where we can interfere. The first point is patient becomes restless and agitated, restless and anxious, but they're still oriented. And the second part is when they become agitated and disoriented. So in our ebook and in this webinar, we are dividing patients into two of these groups where they are anxious but oriented, and as well as agitated and disoriented. So how do you diagnose delirium? How do you find out whether the patient is delirious or not? And there are lots of tools available in clinical practice, but for our purpose, we have actually described a very simple tool which can be used for delirium. Again, it might not be possible to do this in our patient scenario, but this is the simplest one that's available. It's called a 480 delirium assessment tool, where you've got 4 of them. So first one is alertness. And here if the patient is fully alert, then gets a score of 0. But if the patient is clearly abnormal, they're not alert, they get a score of 4. Then second one is AMT4, where you ask the patient about age, date of birth, the name of the hospital or building, and the current year. Again, if they're able to answer without any mistakes, then they don't score anything. But if they have 1 mistake, they score 1, and 2 or more mistakes, they score, or they're not able, you can't test them, they score 2. The third one is attention, where you ask the patient to list the months of the year backwards. And if they're able to say 7 months or more correctly, then they don't score anything, they score a 0. And but they start to say the months, but they score less than 7 months, or they refuse to start saying the months and give a score of 1. And they're untestable. They cannot start because they're unwell. They have a score of 2. And the last one is maybe a bit difficult to assess, because you have to ask or you have to evaluate whether the patient has got an acute change or a fluctuating course. But there's a significant change or fluctuation in the last 2 weeks. Now, this can only be elicited by speaking to family normally. Now, sometimes it's not possible in a current scenario. You can actually maybe telephone call them and ask about that. But if there is a definite change or fluctuating course in the last 2 weeks and it's evident in the last 24 hours, they score a 4. Then how do we diagnose delirium from this? Is if there's a score of 4 or more, it's a possible delirium, and patient goes in the delirium pathway. And as I said, it can go with the patient. This is the simplest tool that's available, and may not be always possible to do it, but that's the simplest one that's available, and it's worth a try. So again, always think of other factors also. Now, this is more relevant to probably general palliative care patients with the delirium rather than COVID-19. Now, COVID-19 has got its own reasons of patient becoming delirious, which includes the breathlessness. We've mentioned that before, which can lead to anxiety, agitation, delirium, hypoxia can cause that, but always rule out other causes. Is the patient in retention? Are they constipated? Are they having any withdrawal syndrome? And this is again, it depends on the different places where you're working. In places where there's lockdown and where the beverages have been shut down, we have patients with withdrawal syndrome in our state. So is it because of that? Are they withdrawing from alcohol? Are they withdrawing from the narcotics that they normally take? So we need to rule that out. And obviously pain. There are reports that patients with COVID-19 can present with severe myalgia, and if that's unaddressed, or they already got some reasons to have pain, they're cancer patients, they've got a pain medication just not being given, and they're in a lot of pain, all this can contribute to delirium. So always think about these reversible causes or the other causes of delirium before we proceed on to managing that and try and correct them. So the management aspect, again, we have got both pharmacological and non-pharmacological management. Non-pharmacological management, you start with how you deal with the patient. So try and healthcare professionals should try and be calm, capable, and compassionate to the patient, and to have the optimal response when they're dealing with it. Now, this is going to be very, very difficult in our COVID-19 scenario, because as we all know, we'll be using personal protective equipment where patients are not even able to see our faces. So we have to be extra careful when we deal with those patients. Try to be gentle, try to be reassuring to the patient. Always try and keep the room airy and lighter as much as possible. Ask them if they want to convey a message to the family. Encourage them to ask any questions that they might have. So always try and help keep the continuity of care with the patient so that they are not confused just because of lack of information. This is the non-pharmaceutical things that you can do, and things like, if they are elderly, their glasses, their hearing aids, all these should be should be addressed initially itself. Now, again, the management wise, according to algorithm, we have divided into two categories. We've got agitated patient who's quite oriented. So in those patients, just like I mentioned in breathlessness, they're very anxious, but they're still oriented. We can start with benzodiazepine. Patients able to solo, we can give a lorazepam 0.5 to 1 milligram twice daily or sublingually. Oral tablet can be given as sublingual, as crushed, or you can give clonazepam 0.25 to 0.5 milligram twice daily. If the patient is not able to solo, we go for midazolam. The dosage is not much different, 2.55 milligram bolus injection, and as and when needed. Now, that's mild delirium. The patient has got moderate delirium, but they're still oriented. If the agitation persists, we have advised to start a continuous infusion of IV or subcut infusion with 10 milligram of midazolam in 24 hours. And again, if the symptoms persist after starting the EPO infusion, then we can have haloperidol 0.5 milligram every 15 minutes SOS, or 1.5 milligram to 5 milligram in 24 hours. So there's an option of starting a continuous infusion. Start a continuous infusion with haloperidol 1.5 milligram in 24 hours and midazolam up to 10 milligram in 24 hours. Then we come to our next group of patients who are agitated and disoriented, which is a delirium. We've done the 480 score and diagnosed them as delirium. You have to start with haloperidol as first line. So give injection haloperidol 1 milligram slow IV subcut or 1.5 milligram per orally. The dose may have to be repeated every hour up to a dose of 5 milligram. Or again, that might not be a possibility because of the risk of infection. So if there's an option of starting a continuous infusion, we can give a bolus injection of 1 milligram haloperidol as IV or subcut, and continuous infusion of 5 milligram haloperidol can be started over simultaneously at the same time after giving a start dose, start as an infusion. Again, if they become moderately agitated, agitation persists, add injection midazolam 1 mg slow IV subcut and repeat every 10 minutes until the patient becomes settled. Or you can give a bolus injection of 2 milligram midazolam IV subcut and a continuous infusion or midazolam 10 milligram started along with the haloperidol. So they become more and more agitated and disoriented. And just like breathlessness, when they become intractably agitated and delirious, so that their end of life, as I mentioned, become high delirium and high agitation. They've got intractable symptoms of agitation and delirium. You start with a maximum dose of haloperidol 20 milligram and midazolam 20 milligram can be given as a continuous infusion. Can be given either intravenous or subcutaneously. And the thing to remember is you can combine these drugs together and give us as a single infusion, just like I mentioned in the morphine and midazolam. In palliative care, we normally combine, sometimes some units combine up to 4 drugs in a syringe driver because they're compatible, depending on the compatibility. And you can use either normal saline or water-free injection, and even up to a maximum 4 drugs can be given sometimes if needed, combined together. So if you can cover lots of symptoms together. And this is the algorithm for management of agitation and delirium, which is given in page 19 of our ebook. And that's algorithm 3. And we have divided that into 2 groups. We've got agitated and disoriented as a delirium, and agitated and oriented patient, which is anxiety, panic, and fear. And I've explained all these in my previous slides. So to summarize, we need to recognize the symptom complex of breathlessness agitation in severe COVID-19 pneumonia. They go hand in hand. To assess delirium, a 480 delirium assessment tool is a quick tool to use. Always remember to assess and rule out and manage other causes of delirium. And for anxiety and restlessness without disorientation, you can start a benzodiazepine. But with restlessness agitation with disorientation, you can start an antipsychotic. We've given lots of, at the end of the slides, we've given some resources, and the important one is, as I mentioned, is the ebook. We've got the link to the ebook and the PALLICARE app, and all the resources that can be used for further reading, both for palliative care and as well as for COVID-19, the role of palliative care in COVID-19. We've got resources available, and also we've given some training opportunities available for palliative care in the country. And I'd like to conclude by thanking you for listening to the webinar, and please give a valuable feedback. We've given a Google Forms. There's a link for feedback. It's very, very important for us to know about our session, as well as anything that you would like to know more about the session, and also for us to know more about you. So please use this link to give a valuable feedback. Once again, thank you very much for listening.